I'd like to welcome everyone to the 374th Inaugural Lecture Series of Maternal University. And this is to be presented by Professor Adebanjo Babalola Adeyemi. The title of this lecture is that our mothers may live and be well. Obstacles to maternal mortality reduction in Nigeria. Professor Adebanjo Babalola Adeyemi is an obstetrician, gynecologist, with 28 years of experience as a researcher, a lecturer, and a clinician in his field of practice. He had his first degree in Bachelor of Health Sciences in 1980 from the University of Ife, now Opafemalo University, and proceeded further in his education in this same institution to graduate as a medical doctor in 1984. He qualified as a fellow of West African College of Surgeons in 1995 after a 6-year period of residency training in Opafemalo University Teaching Hospital, and also got inducted as a fellow of International College of Surgeons in 2014. His zeal for further knowledge in his career took him to places like Israel, the US, South Africa, and Ghana. He was appointed a professor of obstetrics, gynecology, and perinatology of Opafemalo University in 2011, and became the head of the department from August 2018 to July 2021. Professor Adeyemi has been involved in the training of medical students for about 30 years, during which he also served as a counselor to many of them. He has supervised 20 postgraduate students in masters in public health, many of whom have their PhDs. He also mentored at least 25 postgraduate medical doctors in their fellowship programs, some of whom are now consultants and professors, both locally and internationally. His area of research into maternal mortality and reproductive health got him involved in collaborative researches with quite a number of colleagues, sociologists, anthropologists, demographers, mental specialists, and public health physicians. In the past 22 years, he has collaborated in the status of an expert in research works, intervention studies, and training workshops sponsored by MacArthur Foundation, United Nations Educational, Scientific, and Cultural Organizations, UNESCO, Bill and Melinda Gates Foundation, President's Emergency Plan for AIDS Relief, Major Evaluation, Johns Hopkins University, and of recent, London School of Hygiene and Tropical Medicine and World Health Organization. He has been serving the Federal Ministry of Health in recent years as a trainer of trainers in an essential newborn care course. He has 66 publications to his credit in reputable peer-reviewed international and local journals. Professor Adeyemi has over the years demonstrated his passion for independent and collaborative researches aimed at finding solutions to clinical problems in the specialty of obstetrics, gynecology, and perinatology, especially in the areas of maternal mortality and reproductive health. He has also been helping to improve our understanding of the underlying factors to all these problems. I hereby call on Professor Adeyemi to deliver his lecture. Thank you.
Mr. Vice Chancellor, sir, the Deputy Vice Chancellor Academic, the Deputy Vice Chancellor's Administration, the Registrar, the Librarian, the Bursar, Provost of College of Health Sciences and Postgraduate College, Dean of Faculties, Directors and Head of Departments, distinguished members of Senate, distinguished ladies and gentlemen. I thank the Almighty God for the privilege He has given me to stand before this audience to give the 37th and 37th inaugural lecture. It is the 8th inaugural lecture from the Department of Obstetrics, Gynecology, and Perinatology at the College of Health Sciences of our great university, Obafemi Awolowo Ile-Ife. My educational background. I started my primary school education earlier than my peers in 1962 at Abeokuta and ended the last 4 years of the 8-year period in 1969 when I finished at St. Augustine's Catholic Primary School in Ijebu-Ode. I attended St. Anthony's Grammar School, Eshure, Ijebu-Mushin for my secondary school education from 1970 to 1974. After this landmark, a lot of thoughts were racing through my mind as to what to do next with my life. I fell in love with nature, so I spent the earlier part of my post-secondary school period exploring many books to research into the world in which I live. I did quite some study in the life under the sea itself, then the earth and its formation, the sky, the stars, and the galactic system. I had the wish that one day I would pursue space science or geophysics as a career. I kept on with this passion while still working during my brief stint as a court clerk with the Old Western Region and the newly created Ogun State until two of my secondary school mates, Professor Babatunde Tulano and late Dr. Adekoya Ko, who were already studying medicine at the University of Ibadan and University of Liberia respectively, persuaded me that I should consider medicine as an option because of the opportunity it offered in entrepreneurship in this country as of that time. After a careful consideration of our discussion for about a month, I made an alteration in my entrance by interchanging medicine as the first choice and geophysics as the second choice. That was how my journey in the study of medicine began, and there has been no regret. I stepped into the University of Ife in August 1976 for an internship into the then Faculty of Health Sciences and beheld the most beautiful sight I ever saw since I was born. In the way nature and mankind laid the great Ife, Africa's most beautiful campus. I thank God for providing me an atmosphere where my love of nature and desire to study it could blend with a career on the study of man, his challenges in adapting to the environment, and how to treat him when ill. I'm indeed grateful to God for using University of Ife, now Obafemi Awolowo University Ile-Ife, to nurture me from the infancy of my academic career to the rank of a professor. My undergraduate program in medicine spanned from September 1976 to July 1984. It was a time when you needed to spend 7 years to study medicine in this institution. I did my internship at West Eagles Hospital in Ilesha from August 1984 to July 1985, before proceeding to the National Youth Service at General Hospital, Bama, Borno State. After my discharge from the National Youth Service, I joined the services of the state of Nigeria as a medical officer from August 1986. After ruminating over different options, I eventually commenced my journey towards specialization as soon as I started working as a medical officer. I became qualified to study the discipline of obstetrics and gynecology, with my success as the best candidate in my first attempt at the primary fellowship of West African Surgeon in October 1987. I secured a residency training position in the Department of Obstetrics, Gynecology and Perinatology of Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife, in February 1989 and finished as a fellow of West African Surgeon in October 1995. My interest in teaching and research activities and the passion to give back led me to apply to this institution for a lecturing position the following month. However, there was a lull in employment in any universities as of that time as a result of incessant nationwide industrial crisis between the federal government and the university employees. I had the encouragement of Professor R.O. Makonjola, the Chief Medical Director at OHCC Ile-Ife at that time, to stay behind and work in Ife when he gave me an uncommon privilege as of then to be temporarily employed as a hospital consultant. The door eventually opened to me in April 1997 when I started my career as a lecturer in this great citadel of learning. My words cannot fully express the appreciation and the grace and divine favors I have enjoyed from God to surmount many obstacles to attain this professorial status. academic career in Obafemi Awolowo University, Ile-Ife. My field of study as an academic and medical specialist in obstetrics, gynecology, and perinatology. Obstetrics is the field of medicine that is dedicated to the study and care of women in pregnancy, pre-pregnancy, childbirth, and postpartum period, that is 6 weeks after delivery. Gynecology, the science of the physiology and medicine that focuses on the care for the functions and diseases specific to women and girls, with particular emphasis on the reproductive system. The field of obstetrics and gynecology are usually combined as a single discipline in many parts of the world, like the United States of America and other English-speaking parts of the world. Perinatology, otherwise known as maternal fetal medicine, is a specialty in obstetrics that focuses on pregnant women who have chronic medical problems, those at risk of pregnancy-related complications, women with fetus at risk of complications, or those that have already developed complications. I'm standing before you today to give an overview of my 27-year journey as an academic in Obafemi Awolowo University. The scope of my reports in this inaugural lecture will focus on two main areas that form the bulk of my research over the years. They are in two parts. The parts are interrelated and overlapping in their concepts. Section 1 is maternal mortality reduction and high-risk pregnancy. Section 2 is reproductive health and well-being of women. I'm starting with section 1. Some of the key questions that have agitated my mind over time include: why should women die in the process of performing the nature-ordained function of procreation? What can be done to avoid this maternal death? And how can the quality of lives of women be better than it has been in the present-day Nigeria? Thaddeus and Main in 1994 categorized various delays that contribute to maternal mortality into three: delay in deciding to seek for help, delay in reaching health facility, and thirdly, delay in receiving appropriate care. I also wish to know to what extent these factors apply to our environment. Decision, incision, interval for cesarean section. My initial attempt to answer these questions started with a research in West English Hospital in Ilesha, Osun State, where I started working as a young consultant. The burden of maternal mortality in the zone at that time was so morbidly high. My then head of department, Professor Unshe Ongegu, also started to look at the same problem in Ile-Ife, and we had some outstanding findings from this our research. The aim of that work was to determine factors that can be modified at our terminal end as healthcare provider to reduce maternal mortality. The outcome measure was how long it would take to start the process of delivery by emergency cesarean section after decision to do so had been taken. We analyzed 134 cases of emergency cesarean section. Indication for the emergency cesarean were prolonged labor, stroke arrest of progress of labor in 35.5%, failed trial of labor in women with previous CS, 27.9%. In about a quarter, the relative life size of the baby to the pelvic size was the cause of the cesarean section. Fetal distance labor was responsible for 19.5%, preeclampsia for 15.3%, and ruptured uterus for about 14.7% of the cesarean section cases. The decision incision trial was found to range for 30 minutes to 26 hours with a mean of 4.4 plus or minus 4.2 hours. The minimum incision interval for all babies that survived was 30 minutes and median of 3.2 hours, while the minimum for the ones that died was 45 minutes and median of 3.95 hours. All the 5 maternal deaths were linked to multiple delays. 3 of these deaths were associated with the bottleneck at receiving appropriate care at our maternity unit. These include shortage of nursing staff and attendants, lack of basic material like clothes to use for patient, urinary catheter, absence of non-functioning trolley to wheel the patient to the theater, and staff apathy. Delay in availability of a pediatrician to dissociate the neonates when delivery was responsible for about 20%. Unavailability of anesthesis was responsible for delay in 13.6% of cases. Other included non-readiness of the operating theater because there was no surgical grape, no theater gown, or sterile instrument, or lack of surgical materials, insufficient theater nurses, and an ongoing emergency in the only available theater. You can see table 2 for some of these items I've enumerated. Table 2 as shown. Unfortunately, the pattern of these contributing factors remains similar even after 2 decades, when researchers in the department conducted a similar audit in OHAC in 2018. You can see that as outlined in Table 3. The effect of educational intervention on emergency obstetric care. Within the first 3 years of my research and service in the 2 tertiary institutions of OAU and OHAC, it became obvious that the obstetric problems that came to us in the hospital had their roots in the socio-cultural and religious background of the patients. Therefore, the need to move down to the community from the ivory tower to associate with people in order to unravel some of these factors that were leading to maternal mortality and morbidity became critical. In the course of my work, I identified and joined a research group in the university with the same focus and passion. The research group consisted of an anthropologist, Professor Bisaino, a demographer, Professor Alfred Adeyemi, a medical sociologist, Professor Stein Walbrecht, and a geographer, Professor Yinka Adeshina. We mapped out the whole of Fortune State as our research field and finally selected Ejigbo and Ayegbajo and Odeumu based on their similarities as our study styles. We use a variety of data collection techniques, questionnaire survey, focus group discussion, direct observations, exposure to educational materials like talks, discussion, films, and drama. The study was carried out over a period of 18 months from July 1997 to December 1998. The baseline survey lasted 3 months, intervention phase lasted 12 months, and post-intervention lasted for 3 months. We found out that the culture of male supremacy was a major determinant of pregnancy outcome. Men had absolute control over the choice of health facilities during pregnancy, the condition under which delivery took place, diet during pregnancy, and types of action taken in emergency obstetric conditions. Was it because these men were wicked or selfish? The answer was no. The story revealed that most men lacked knowledge of what constituted an emergency obstetric condition, had shallow knowledge of appropriate actions to be taken at each stage of pregnancy, and poor knowledge about fertility and family planning. Following the conclusion of this study, the next question was, can education change this? This question led to the intervention program, which was aimed at improving the knowledge of men with what constituted an emergency obstetric treatment and counseling on male supremacy behavior, which might be detrimental to pregnancy outcomes and the social dynamics at what constituted a healthy family. Decision-making process in reproductive health in sub-Saharan Africa is a complex activity dictated by customs, religious belief, socioeconomic factors, and cultural innovations. The central role played by men in this process gives a strong justification for health education intervention with focus on men. A quasi-experiential study among couples in the Ejigbo, Odeumu, and Ayegbajo was carried out. Ejigbo and Odeumu serve as intervention terms while Ayegbajo serves as the control. In the intervention phase, we visited churches, mosques, and attended trade union meetings in the selected towns to provide information and education on issues related to reproductive health with emphasis on the role of men using posters, handbills, public lectures, workshops, and film shows. After the intervention phase, we assessed how decisions were made on the need for pregnancy, timing of pregnancy, seeking of postpartum care or post-miscarriage care, and husband support for wives during pregnancy. The assessment showed that more couples took joint decisions on taking care of pregnancy, more husbands supported their wives during pregnancy, and more women sought postpartum care in Ejigbo and Odeumu where the intervention were carried out, compared to Otan Ayegbajo, which served as the control. We concluded from this study that enlightenment of men is a faster and effective short-term measure to improve women's utilization of reproductive health facilities. Time motion study of patients attending Obafemi Awolowo University Teaching Hospital Complex. Following our previous research into decision delivery intervals for cesarean section, there was need to understand in more details the series of what happened to patients from the time of arrival at the hospital until the time of delivery, either spontaneously through the vagina or by cesarean section. This led to the study titled Time Motion Study of Obstetric Emergency in OHJC Ilefe. In this study, a client flowchart was designed to collect information at the time of arrival in labor ward and at which various activities were carried out on the patients. 96 women with obstetric emergency were investigated. The delay in delivery were mostly in subjects requiring emergency cesarean section. The major cause was inadequate operating theater space and inconsistent electrical power supply to the labor ward theater. The delay had significant relationship with perinatal and maternal complications. Comparison of booked and unbooked pregnant patients. According to health belief mullet theory, individuals are more likely to adopt a health behavior if they perceive themselves to be at risk of a particular disease, believe that the disease has a severe adverse effect, and that action taken to prevent or treat disease is beneficial and feasible. Health-seeking behavior is related to the outcome of pregnancy. With this concept in mind, in 2008, I collaborated with some colleagues to undertake a prospective study spanning 2 years to compare pregnancy outcome between those who utilized antenatal services and those who didn't. We found out that those who did not register for antenatal care but came at the time of delivery were likely to be younger in age, unmarried, less educated, belonged to lower socioeconomic class. They also tended to have had more children. Furthermore, the babies of those who had not used antenatal care services are 3 times more likely to have breathing problems at birth, asphyxia. Table 7 can show you the comparison. It's obvious. You can see in table 7 as shown. Determinant of antenatal booking. Having noted the differences between the booked and booked patients, we sought to determine additional factors, apart from the demographic differences that may influence the decision to seek for antenatal care in hospital. The expected benefit was to be able to identify areas needing education intervention to improve the booking rate. The thought generated another research, and I led a group of obstetricians, nursing scientists, and a medical health specialist to investigate the determinants of antenatal booking time in a southwestern Nigerian setting, with 327 pregnant women as study participants. Top on the list of factors that influenced booking was the educational level of the husband. The higher it was, the higher the probability that the woman would book for antenatal care. The other major determinant included history of previous miscarriage, medical problem in the index pregnancy, and parity, how many children she had delivered before, were also associated factors, though they were not statistically significant. We concluded that educational level of women may not easily translate to optimum utilization of antenatal services unless some of our socio-cultural and religious mindset were modified by health education. Table 8 can show, you can see from that table 8 some of these significant factors between the book, when comparisons were made between booked and unbooked patients in table 8. Essential obstetric care at the Grassroots in Osun State. Most of the deliveries in Nigeria take place in health facilities outside the tertiary institutions. If there is going to be any significant improvement in the quality of care of pregnant women and reduction in maternal mortality, it should start from the grassroots. The study was conducted to determine the unavailability of essential obstetric care services in Osun State using Ife South local government area as a model. After careful selection process, 26 health facilities were surveyed. 21 of these were public facilities and 5 were privately owned. None of the facilities had basic equipment and supply needed for emergency obstetric care. 3 of the facilities employ qualified nurse midwives. No health worker in the whole of the local government area at that time had ever been trained in life-saving skills. The study concluded that there were major deficiencies in the supply side of obstetric care services in the local government area. This has serious implications for maternal mortality reduction, and there was no evidence that the situation will have changed for the better. So you can see from that table 9 some of the supplies that were deficient, some that were available, others that were not available. The use of pathogram in the management of labor. Nigeria records about 67,000 maternal deaths annually, the highest in the world. Significant proportion of these deaths are attributable to direct or indirect effect of prolonged and obstetric labors. Other causes of maternal deaths, such as postpartum hemorrhage and puerperal sepsis, are closely linked to the abnormal course of labor. Therefore, any intervention to reduce the incidence of prolonged obstetric labor will impact positively on reducing maternal mortality. One of the major tools in monitoring labor that can help to reduce the incidence of obstetric or prolonged labor is pathogram. It is a tool that presents the progress of labor in a graphical form. The use of pathogram has been restricted to tertiary institutions in Nigeria, whereas most fertility-based delivery take place at primary and secondary health care facilities. Consequently, myself and a group of lecturers from both the Department of Obstetrics and Gynecology and Community Medicine initiated a training in the use of pathogram for primary health workers like doctors, midwives, and community health extension workers, using Ife Central Local Government Area of Osun State as a test case. The evaluation of the training undertaken 7 months later showed that primary health workers and the lower cadres of health workers can be trained to use pathogram with satisfactory results. These findings have significant implications for efforts to improve maternal outcome in low and medium income countries with scarcity of skilled attendants, doctors and nurses. You can see post-training performance of nurse midwife and community health worker in the use of pathogram from table 10 as projected. The role of contraception on maternal health. Maternal mortality is not just a medical problem. It's a socio-cultural problem as well. In fact, socio-cultural factors operating in the lives of female gender from the time of birth have complex interaction with socio-economic environment to give birth remotely or proximately to the medical causes of maternal death. Among the immediate causes of maternal death in Nigeria globally is excessive bleeding in pregnancy, obstetric hemorrhage, which when one combined with unsafe abortion, constitute about 40% of maternal deaths. These two problems have a common pathway of prevention through the intervention of contraception and family planning. These highly cost-effective medical interventions work by tackling the notorious 40s in obstetric passes. That is, pregnancy that occur too soon, too late, too frequent, and too many. These 40s often result in obstetric hemorrhage and unsafe abortion. As part of my research work, I tried to find answers to 3 questions related to this issue of contraception and family planning in 3 phases of research spanning between 2005 and 2011. The first question we ventured to ask was, what is the gap between the actual need for contraception and those who are actually using it in this environment? In the second phase of research, we tried to find out what factors are modifiable in the lives of women who tend to have large number of children, that is greater than 5, that will influence the use of contraception. The third question we tried to answer was, why do high rates of unwanted pregnancy and abortion persist in this part of the world, even among married couples, despite widespread awareness and access to modern contraception and the legal restriction in the first place? So the first research is as follows. The unmet need for contraception in Nigeria. A prospective study of 256 women attending antenatal clinic at OHAC Ilefe was carried out over a period of 1 year between 2004 to 5. It revealed that about 60% of women needing contraception and family planning did not use them despite high level of knowledge, awareness, and good educational background. It became obvious that social, cultural, and religious factors were critical areas that intervention to increase contraceptive prevalence usage should focus. We also found that there was much misinformation about the side effect of contraception among the people. We see that in table 7, some of the reasons for non-usage in the table 11 as shown. Contraceptive use among grand multiparous mothers. A grand multiparous woman is someone who has had more than 4 pregnancies beyond the age of viability, which is taken at 28 weeks by the Nigerian law. The second research in this team showed that close to 10% of our women population have had 5 or more deliveries. At least 80% of this group completed secondary school education, and 65% were in monogamous marriage. We found that preference for a particular sex was the motivational factor that often led to giving birth to many children in this environment. It was noted that high literacy rate in the population of women did not impact positively on reducing the unmet need for contraception. Health education about gender biases relating to sex preferences was highly necessary. The study population was also noticed to be ignorant of the aspect of permanent contraception like bilateral tubal ligation, even though they knew about others. Contraception was not approved by the husband in about 30% of the study participants. The role of men in supporting contraceptive usage by their wives needs to be promoted if family planning programs are to succeed. So we see some of the paternal factors, and the contraceptive intentions, the factor that determine whether they want to use contraception or not, in table 13, as shown. Unwanted pregnancy and induced abortion in southwest Nigeria. When viewed globally, the prevalence of contraceptive use was 63% for any method and 49% for modern method. 6 out of 10 unintended pregnancies end in induced abortion. 45% of the abortion are unsafe. 90% of the global estimate of abortion take place in developing countries. 73 million induced abortion take place every year. 220 women die for every 100,000 of unsafe abortion in low and middle income countries. 200,000 unsafe abortions are done in Nigeria every year, and 40% of such develop complications. The proportion of pregnancies that end up being aborted vary from 11% in southwest of Nigeria to as high as 70% in south region of the country. Many married couples still use induced abortion to regulate fertility. Despite this, unwanted pregnancy and abortion rates are still relatively high, with an average rate of 63%. Induced abortion are a leading cause of pregnancy-related deaths. It could be as high as 30% of the cause of maternal death in some regions, and 60% of such women are usually below 65 years. In the light of the above information, Professor Mideye Eke and myself team up with some other collaborators to research into induced abortion in southwest Nigeria with the objective of learning how women and men talk about social norms regarding abortion and contraception, the essence to which contraception was used to proactively to prevent unplanned pregnancy, explore the decision-making role of both sexes, and reaction to unwanted pregnancy. Our findings with regard to attitude towards unwanted pregnancy show that people resorted to abortion to prevent unwanted births. The reason for the unwanted pregnancy included incomplete educational attainment, immaturity, economic hardship, perceived bad timing or close pregnancy interval, and social stigma. Among the single women, an important reason to abort was the fear of getting into trouble with their fathers or being discovered by the family. Procurement of abortion was thought to be relatively more difficult in younger unmarried women, and the onus was usually on the woman to take care of herself. In rural areas, people often get into problems of unorthodox method of contraception like charms, in form of armbands, waistbands, and rings. The study also showed that some married men seldom knew about the attempts of their wives to terminate pregnancy, especially if they had conflicting views as to what to do with it. However, male partners who consent to abortion usually bear the cost. In 2 out of every 3 cases of unwanted pregnancy in unmarried ladies, the decision to abort often ended the relationship abruptly. Men generally like to be informed about contraceptive usage of their wives, as unilateral decision could strain a pre-existing level of intimacy. To state it briefly, the relationship between abortions and contraceptive practice is a complex one. Inconsistent and ineffective use of contraception results in unwanted pregnancy in Nigeria. Family planning programs might have failed because men were not adequately taken along. It is important to educate men on contraception and family planning so that they can be involved in joint decision making and have shared responsibility if and when complications arise. Teenage pregnancy. A teenager is a person between the age of 13 to 19 years. An adolescent is a person in the transitional phase between childhood and adult from ages of 10 to 19. Teenage pregnancy was found to be a major cause of unsafe abortion in Nigeria. And unsafe abortion is accountable for up to 30 to 40% of overall maternal deaths. In Nigeria, 73% of deaths in women below the age of 19 years were the result of complications of abortions. Hence, our qualitative study was entitled Analysis of Parents and Adolescent Concern on Teenage Pregnancy in Nigeria and How to Prevent and Manage SORS. Coercive sex and rape predominated as causes of teenage pregnancy. The highlight of the findings were that male and female parents were in agreement that they needed to relate more closely to adolescents to be able to monitor them as they develop into adults, and to be warning girls to stay away from boys who might spoil their lives. On the other hand, the consensus about male and female adolescents was that the affected girl should be taken care of and not sent out of school or sent out of home, as some parents will do. Mr. Vice Chancellor, sir, the research I'm about to present is my most cited work. As of June this year, I have more than 1,000 citations. This is postpartum hemorrhage. Postpartum hemorrhage is a condition of excessive blood loss after childbirth. It occurs when a woman has more than 500 ml of blood after a vaginal delivery, or more than 1,000 ml after a cesarean section. Postpartum hemorrhage is the leading cause of maternal death worldwide. And any intervention that reduces blood loss at delivery will bring down maternal mortality considerably. Early administration of tranexamic acid had been found to reduce blood loss in trauma patients following road traffic accidents. With this background, a team of obstetricians worldwide, of which I was the one, assessed the effect of early administration of tranexamic acid in reducing the risk of maternal death, hysterectomy, and blood loss in women with postpartum hemorrhage. The study enrolled 20,000 women worldwide between March 2010 and April 2016, and randomly assigned to them either to receive tranexamic acid or placebo in addition to the existing protocol of managing postpartum hemorrhage in the individual study sites. The concluding findings revealed that death due to bleeding was significantly reduced in women given tranexamic acid, especially if administered within 3 hours of giving birth. We therefore recommended that tranexamic acid should be included as a standard treatment of postpartum hemorrhage and should be given as soon as possible after bleeding onset. Mr. Vice Chancellor, sir, this recommendation was internationally accepted. It is now a WHO recommendation in obstetric path. And this is my, yes. So slide table 14 and show you, comparison between those who received and those who didn't receive. You can see the significant differences as of shown in table 14. Companionship in labor. Labor and delivery are both physically challenging and can be associated with psychological stress. Good outcomes are not always guaranteed, especially in low-income settings. Over time, the scope of social and psychological support experienced by women during labor has changed considerably. One of the welcome changes is now to allow a close relative to practice companionship during labor. Several studies have reported positive effects like reduced analgesic requirement, better sense of satisfaction, and healthier babies immediately after birth. In Nigeria, Only about 36% of pregnant women deliver under a skilled supervision, and this is a factor making Nigeria a leading country in the world in maternal mortality ratio. The practice of companionship in labor could potentially enhance women's experiences in facility-based delivery and improve the national statistics regarding maternal and neonatal deaths. Furthermore, this approach could reduce mistreatment and abuse in labor, which are documented to occur in some of the Nigerian healthcare settings. We initiated one of the earliest studies on companionship in labor in Nigeria to determine the preferences for companionship during labor among women, the preferences among the male partners, and preferences of the health workers, and to identify factors associated with approving such approach. Our findings show that 90% of health workers support companionship of relatives in labor. Ironically, in this environment, majority of our delivered mothers, 78%, and their male partners, 77%, do not support companionship from any other group of people or relatives apart from a sympathetic and empathic midwife or a doctor. Having a relative around was considered an undue interference by the couple for many reasons. Among the minorities, that is 20% for development or 23% of the partners who prefer companionship in labor, there were complaints about the design of our labor world, which did not allow for privacy. In conclusion, this study suggested the need for education of both women and their partners to ensure that the strategy of companionship in labor gained ground in Nigeria. However, such an effort must be complemented by appropriate redesign of labor wars in public sector facilities to ensure privacy and lack of overcrowding. Mr. Vice Chancellor, sir, as the title says, that our mother may live and be well, we are moving to the second session, the productive health and well-being of women. I'm starting with my work on minimal access surgery. Minimal access surgery is a procedure in which access is gained into the inside of the abdomen and pelvis without having to make a large incision on the skin. The technical term of such procedure is laparoscopy. Laparoscopy is more rewarding than large incision in terms of cosmetic appearance of scar, faster recovery, lower infection rate, less pain, less blood loss, and very early discharge from the hospital and fewer complications. Laparoscopy was introduced in medical practice in 1901, about 120 years ago, by a German gynecologist called George Kelly. It became popular as a diagnosis tool from 1960, and by September 13, 1980, the first operative laparoscopy was performed in Germany to improve an inflamed appendix. By virtue of better economy and better management of resources we had then in Nigeria, laparoscopy had been introduced in Nigeria by the early 80s, including OHSC. Due to lack of adequate funding and good maintenance, the practice had dwindled away by the year 2000 AD. After a lull of about 1 decade, there came some intervention fund that helped to revitalize some of our infrastructure, and a new set of equipment was purchased. This equipment can enable diagnosis by laparoscopy and can also be adapted to perform surgical procedure with incorporation of video camera and adapted TV screen. I had the privilege of being retrained in operative laparoscopy through a fellowship in Israel. The fellowship also included exposures to robotic surgery. While contemplating on how to resuscitate laparoscopy procedure and surgery in our department, a junior colleague, Dr. Olusegun Koko, with training in laparoscopy surgery, also arrived from India. While in India, he had an opportunity of a large number of patients to practice with and learning to improvise, as India belongs to low and medium income countries. We teamed up and performed the first operative gynecological laparoscopy in OHSC in November 2011. Within a span of 1 year thereafter, the Department of Obstetrics and Gynecology in OHSC had become a leading center in gynecological laparoscopy in Nigeria. The first reported case of total laparoscopic hysterectomy in Nigeria was performed in OHCAC in September 19, 2012. So we can see the laparoscopy procedure. You can see the woman. Yeah, that was the first laparoscopy procedure. You can see the uterus that was removed. Yes. You can see the abdomen after the surgery. You can hardly see the scar of the surgery, and the woman was discharged within 24 hours. As the unit became well established and gained strong footing, so I felt that one of my dreams had been fulfilled. I relinquished the leadership of the unit to Dr. Badejoko and became more visible in the areas of maternal fetal medicine. Unfortunately, there's another load in gynecological laparoscopy unit, and this has lasted for about 5 years now. It has been difficult to sustain the high momentum with which the unit was advancing, as the equipment and the necessary consumables lack financial backing to maintain them. I'm using this opportunity to call on hospital management in OHCAC to consider this challenge as a priority. Violence against women. Violence against women is the commonest form of violence existing in human race, and it's a major reproductive health issue of our time because of its many negative reproductive health implications. Intimate partner violence is one of the major forms of violence against women. National Demographic and Health Survey of Nigeria of 2018 showed that 33% of women in productive age in this country have experienced physical or sexual violence. Most of these problems may not be obvious when they present in the hospitals. As healthcare providers, we have important roles to play in the diagnosis, treatment, and prevention of these societal problems. I initiated some studies with the aim of determining the knowledge, attitude, capacity, and action of healthcare professionals on these issues, and make recommendations on the training needs of doctors and nurses in this area. The results showed that the knowledge of doctors and nurses in Southwest Nigeria was generally poor. The breakdown of the findings showed that 38% of cases may not be identified by doctors and nurses. 42% of identified cases will not be properly managed. Majority of healthcare workers, that is as high as 87.5%, have at least one form of poor attitude towards victims of intimate partner violence. And 58% of instances, health workers will not take affirmative decisions in favor of the patient for fear of introducing too much into the couple's privacy or breaking marital relationship. You can see. We concluded that in order to meet the challenges of violence against women and its possible contribution to poor physical and mental health of women, there is need for doctors and nurses to be trained on routine screening of violence against women or intimate partner violence, and to be able to provide appropriate care to the survivors. As most of the survivors will not directly give information about experiences of abuse and violence, the need for high index of suspicion on the part of health workers is important. Fourth, their capacity and competence need to be improved to respond holistically to the challenge of primary, secondary, and tertiary prevention of violence against women. This is when they can also plan their strategic role in advocacy, prevention, and management of violence against women. Mental state of our pregnant and delivered mothers. Pregnancy is a physiological state with many temporary physical changes in the body structure and functions. There are also changes in the mental state of pregnant women. These psychological changes can follow in the positive direction depending on interplay of genetic constitution, social and cultural environment, complication and outcome of pregnancy, labor, and puerperio. In the spirit of total care, I did some work in collaboration with mental health specialists and a clinical sociology to look into some aspects of mental state of our pregnant women over a period spanning 5 years. First, postpartum depression following normal delivery was investigated. Secondly, we determined the relationship of obstetric and sociocultural factors to anxiety and depression in late pregnancy. Thirdly, we tried to determine the predictors of high postpartum psychological symptoms in women who have had difficult deliveries. Finally, we tried to identify variables associated with depressive symptoms in women shortly after perinatal loss, that is, shortly after losing their baby. The findings from this study indicated that, firstly, there was a significant relationship between postpartum depression and not having male children, being the first birth, education received during delivery, or absence of or presence of spousal support and polygamy. Secondly, a pregnant woman has a significantly higher level of anxiety and depression compared to a non-pregnant woman. The implication of this is that people need more patience with pregnant mothers, and they need more encouragement at this phase of life. Thirdly, a difficult delivery, though associated with higher level of symptoms, was not predictive of postpartum depressive and anxiety symptoms. Finally, depressive reaction following perinatal loss is very common. Programs need to be designed to help these women cope with their loss and to reduce subsequent psychological morbidity. Prevention of mother-to-child transmission of hepatitis B virus. About 2 million people on Earth show evidence of past hepatitis virus infection. 296 million people are chronically infected. About 820,000 people die each year from liver cirrhosis and hepatocellular cancer, which are caused by hepatitis virus infection. 30 to 50% of hepatitis virus infection are acquired from mother during pregnancy and childbirth. In Nigeria, about 20 million people are seropositive for hepatitis virus, and 130 million show evidence of past infection. Hepatitis virus kills people when they are in their 40s and early 50s, when most of them are around the peak of their success of their career, at a time when children need the support of their parents most. With this background in view, the WHO target is to reduce hepatitis virus infection to less than 0.1% by the year 2030, thus preparing to raise up an almost hepatitis-free generation of people. As part of our contribution to this noble agenda, a group of us led by Professor Dennis Ndububaulu Afemikuti assessed the impact of prevention of mother-to-child transmission of hepatitis virus. We made intervention on transmission of hepatitis virus to infants. Between 2015 and 2011, we undertook the routine screening of all pregnant women for hepatitis virus infection to identify those who are positive. We investigated about 395 positive clients to determine the extent of any ongoing chronic illness or the degree of immunity and the risk of transmission. Antiviral drugs were administered to pregnant women who had a high risk of transmission. The neonates received serum to block the activities of any virus that might have gotten into the baby system within 24 hours of birth. The mothers were also encouraged to get the infants immunized with the birth dose of hepatitis virus vaccine within 24 hours of birth. With our measures, we succeeded in preventing 100% of the children exposed to hepatitis virus to their homes from getting it. We can now broadly recommend this measure to be incorporated into obstetric and midwifery practice in all low and middle income countries all over the world. Following the initiative of our group, the management of OHSC has adopted our recommendation to ensure that all babies delivered in the hospital get the birth dose of hepatitis B vaccine before discharge, which means all babies delivered in OHSC shall henceforth be most likely be completely free from the scourge of hepatitis virus in their generation. Ovation to OHSC. Mr. Vice Chancellor, sir, I'm about to talk about my teaching services and services to the community. Since joining this university, I have taught 24 sets of medical students, which amounted to nothing less than 2,000 doctors, some of whom are consultants and professors in our teaching hospital in other parts of Nigeria and some other countries. I've also been involved in the teaching of maternal and child health in the Department of Nursing for about 20 years now, and the teaching of surgical conditions amenable to physiotherapy in the Department of Medical Rehabilitation for about 10 years. I have supervised 20 master's degrees in this university, some of whom now have their PhDs, and at least 30 fellows of Nigerian Postgraduate Medical College of West African College of Surgery. As regards to service to academic bodies and community, I'm an assessor for professorial cases for both within and outside Obafemi Awolowo University. I acted for the head of the department on at least 36 recorded instances until I became a substantive head of department in 2018. I have served in membership of committees of department, faculty levels upward from 2004. I'm an ambassador to International Federation of Gynecology and Obstetrician and First Fistula Foundation in California, USA, in the campaign to end fistula in Nigeria and worldwide. The pictures showed an award ceremony in appreciation of my contribution to reduce the scourge of fistula in Ife-Jesha zone in Nigeria. I've been a member of planning committee for masters on PhD and masters, committee on establishment of society, member committee on implementation of adopted medical curriculum on sexual and reproductive health, member of College of Health Sciences Curriculum Review Committee, College of Health Sciences Industrial Ceremony Planning Committee, Committee on Continual Professional Training, College Alumni Relation Committee, member Sexual Violence Prevention Action Group, and I've been a member of local organizing committee that hosted International College of Surgeons. I represented my faculty at some period in the Faculty of Board of Science, Faculty Board of Basic Medical Science, and Institute of Oncology. I'm a trainer for the Federal Ministry of Health on Essential Newborn Care, an external examiner to Ladoke, Akitola University, Ogbomoso, Oyo State, Bowen University, Iwo, Osun State, University College Hospital, Ibadan, University of Medical Science, Ondo City. I've been involved in OHTAC prevention of mother transmission of HIV, and I'm a president of Osun State Society for the Study of Pain, an annual guest lecturer, Christ Apostolic Church Missionary Health Workers Annual Convention from 2014 till date. I review for Ethics and Research Committee of OHTAC Lefe, African Journal of Reproductive Health, Tropical Journal of Obstetrics and Gynecology, West African Journal of Medicine, National Postgraduate Medical College, Journal of Demography and Social Statistics, Tertiary Education Fund, and recently, International Journal of Obstetrics and Gynecology. Conclusion. Maternal mortality in Nigeria is still very high, and this is highly unacceptable. The estimated current rate of 810 per 100,000 live births is high. The global trend has shown a significant decline in the last 20 years, but the drop in the rate has either remained stalled or very low in various parts of this country. This ugly situation is caused by interactions of a number of social, economic, cultural, and political factors. The health sector is poorly funded, and majority of the population have to pay out of pockets, especially the poor people who need intervention more. Patient needs to pay for procedure, drugs, and investigation before they can receive adequate treatment. This results into various delays in response to emergency situation in the pregnant mother or the fetus, and can further lead to maternal death, stillbirth, or neonatal deaths. The tone of this poor funding is set by the federal government, and it flows down as a habit to the levels of the state and local governments. Nigeria is yet to implement the World Health Organization guideline to commit 15% of the annual budget to health sector. There are poor organizational structures in place at all tiers of health services, the primary health centers, the general hospital, and the tertiary institutions. The resultant effect of this is the poor capacity to maximize even the available scarce resources. At individual levels, we observe that prompt presentation at health facilities and utilization of the available facilities may be hampered by religious and cultural beliefs. These have a stronger influence, as revealed in some of our studies, than the low attainment of Western education. Nevertheless, low level of education was still found to be an important associated factor in many of the problems and deaths associated with pregnancy. The long waiting period before a patient could receive adequate care on arrival at the hospital, poor attitude on part of healthcare providers and patients have all been found to be significant factors in the poor quality services to pregnant women. And this may not be unrelated to the unconducive working environment and today's skill and practice, including knowledge deficit in some areas, especially when it pertains to issues of reproductive health. My recommendations. The best approach is for the Nigerian government to make maternity service to be free nationwide. Nigeria has the capacity to achieve this if it could curb widespread corruption within the country and manage our resources prudently. Political commitment on the part of federal and state government is a critical step in reducing maternal mortality. The following practical steps can be taken to address the menace of maternal mortality in Nigeria. There is need for reorganization of maternity services nationwide such that we reduce drastically the time interval between patients' arrival at hospital to the time of receiving definitive care. The surgical pass system that was put in place in the early 1980s should be reintroduced wherever it has been abandoned, or make to run efficiently where it is not doing so. This will make it possible for the patients requiring surgical intervention to be provided with all the necessary drugs and consumables that will be needed when emergency arises, even if the patient will have to pay out of pockets later. Efforts should be made to enroll all women of reproductive age in the National Health Insurance Scheme, OHIS. At the moment, the scheme are reaching out only to those employed by the government. The need for increased budgetary allocation of health sector to 15% of the government's provident, as recommended by WHO, cannot be emphasized. Religious bodies should be considered a very good potential collaborators by program officers and policymakers that when they need to reach out to women in order to change some health behavior. Our experimental research in Osun State has proven that. Consideration should also be given to incorporation of men in early health intervention targeted at women. The teaching on identification and management of all forms of intimate violence or violence against women should be properly incorporated into the curricula of all medical and nursing schools. Regular refresher courses should be organized at each institution for maternity staff in order to maintain the efficiency of managing women during pregnancy, labor, and burial. Mr. Vice Chancellor, sir, I give glory to the Almighty God, who is in infinite grace, has allowed this day to become a reality in my life. I appreciate all of you here with me who have come to grace this occasion from far and near. I also thank all my audience, both in Nigeria and in the diaspora, who are participating on various virtual platforms. The numerous people I've encountered have influenced my life significantly, and who have shaped my attitude to situation and contributed directly or indirectly to my success in life. I remember my late father, late Pathophilos Adeyemi role in showing us to trust only in the power of God and to learn to be honest and trustworthy in life. My mother, late Mrs. Beatrice Drogola Adeyemi, showed by example that persistent in hard work will eventually bring success. I spent the greater part of my childhood with my auntie, late Mrs. Comfort, and her husband in Jebode. I learned from them to be diligent and paying attention to details in whatever one does. I learned courtesy and respect for people regardless of their status. And my husband taught me to be patient with women as a role model. I thank all my siblings for their spiritual, psychological, and financial support during the course of my training as a medical student. I cannot forget Professor Alfred Adeyemi and late Professor S. Oguneye, who introduced me to research method I learned in my career. I also remember the early mentorship of Professor Bisa Eno on how to evaluate reproductive health issues from gender perspective. I appreciate the encouragement and all the promptings to be more productive that Professor Adeyemi gave me when he was the provost of the College of Health Sciences. I could recollect the useful advice on how to move forward for my cousin, Professor Abiodun Budaino of Faculty of Pharmacy, and Professor Yinka Adesina of Department of Geography when my academic progress appeared to have stalled at one point. I thank Professor Udiegu and late Professor Dare Francis, who encouraged and ushered me as an academic staff into the Department of Obstetric Gynecology and Perinatology in Obafemi Awolowo University. I appreciate all my research collaborators within the department over the years, like Professor Shola Fashuba, Ernest Oji, Femi Kuti, Femi Makinde, Alex Wolabi, BC Loto, Kayode Ajenifuja, Dr. Tade Jarotimi, Segun Badejoko, Ibrahim Awowole, Clement Adepiti, Akintunde Fentola, and all the hospital consultants in the department. Outside the department, I appreciate collaborative efforts of Professor Segun Fatusi Ebun Adejugbe, Kayode Jajola, Professor Lola Inuoye, Kayode Masaku, Bola Ola, Ejitope Ogunbodede, Denis Ndububa, Dr. Shidio Zembada, late Professor Femi Fatoye, and late Professor Mrs. Benedicta Oladimeji. I also acknowledge the contributions of Matron Sitila Yonyame and Laide Lawa, both retired world leaders in midwifery at OHTAC, for their logistics support in some clinical research involving maternity. The latter matron also helped us to promote men's involvement in antenatal care attendance that emanated from our research in the year 2018. I thank Professor Wumi Fatusi, Professor Segun Fatusi, Professor E.T.O. Babalawa for their editorial assistance on the manuscripts of this inaugural lecture, and all members of my inaugural lecture committee for the success of today. I thank the leadership of the Chapel of Grace for their social, spiritual, and logistic support to making this day a huge success. To my children, Adetunji, Omodunke, Adenisola, Oluwagbemiro, Stephanie, and Taiwo, I thank you for supporting my cause and sharing my vision. I also thank you that at no time did you create distraction from my work. May you all be great in life. Amen. I thank my jewel of inestimable value, Mrs. Esther Olusomi Adeyemi, who created the conducive environment that enabled my vision to succeed, to grow, and to blossom. May God continue to bless you mightily in Jesus' name. May God grant journey mercy to all those who have traveled down to attend this occasion. I thank you all for listening. God bless you all.